have just heard from Yang, I thought I would begin by talking about older people in the pandemic because that is hopefully still fresh in minds. Even I had that hiccup there. Um, Very much of what he said resonated with some research that Mental Health Foundation did recently with Independent Age, and I think one of the key learnings from this, as he has already said so clearly, is that digital connection and virtual contact are valuable. And in the absence of other options, they have, of course, been a lifeline for many people. But they are not a panacea for personal connection. And whether that is with regard to social connection and reducing loneliness or increasing loneliness, um, or healthcare. We know that a lot of healthcare now has moved towards using digital mechanisms. And certainly our research also found that this was problematic for quite a lot of people. Often older people and others will have long-standing relationships with their GPs and other people providing healthcare, and moving all of that onto a digital platform without also making other sources of information and advice and contact available needs to be very much considered. And we need to, I think, pull back from a sense that because we've been through this pandemic and these means of contact have helped us all, and indeed are helping us now to have this event, it doesn't mean that this is necessarily optimal when we are able to use other forms of contact. Older people's needs and preferences, therefore, must be fully considered and respected. We know that postal contact, the use of landlines are also important if you can't see people face to face, but seeing people face to face is a vital element for all human contact. It's interesting to think, of course, that what we don't have when we are connecting virtually is we don't have the physical presence of other people. We're not able to hug them, to kiss them, to reassure them in ways that are non-verbal. This is, we know obviously humans are highly social beings, and that does include that physical contact in all its many expressions and what it does for people, as well as simply being able to communicate information and feelings verbally. So we do need more later life plans and targeted government campaigns that should focus particularly on social connection, reducing loneliness. We've heard already how we knew before the pandemic that this was important for older people. Bereavement support, the restrictions that there were on funerals and our usual ways of grieving and again supporting one another were all taken away necessarily during the lockdowns. But this has meant that many people will experience a complex bereavement reaction, more people than would have done before. And we need to think about routes to treatment and care that will bolster mental health. We do know that the Improving Access to Psychological Therapies program, through data from that actually older people have really, compared to other members of the population, do have very good rates of response to that type of support. So again, that needs to be considered we need to know how to identify depression in older people and open up more access to treatment and support to help with that. And other approaches should include peer support approaches, and these should be co-designed with older people. I think we all know that people know very well what types of things will help them, and they need to be consulted about this and involved in finding solutions. So I would like to just move on now to talk more broadly about what we have seen consistently from the data that Tamsin presented, particularly this morning, and other studies, that what the pandemic and its associated lockdown restrictions have created is a situation where we've seen a very strong unequal distribution of mental health impact, and it has widened pre-existing inequalities. I think everyone will be aware that when we came into the pandemic, we were not in anything that could be described as a perfect situation with regard to mental health. And Tamsin has already presented very helpfully much of that data. We also had a period of austerity and cutbacks in local authorities, for example, of many of the things that we know are supportive and protective of mental health. So, for example, children's centres, youth centres and youth services. The Mental Health Foundation has been conducting its own cross-sectional longitudinal study looking at how people have been affected by the pandemic. And we have, again, there's consistency here with what we've heard already. There will be no surprises here that we have found that it's unemployed people, single parents, young people aged 18 to 24, and especially with regard to loneliness, in fact, people with pre-existing mental health problems and those with long-term conditions who have been especially and consistently negatively affected in terms of their mental health. The COVID-19 Marmot study, Build Back Fairer, very clearly goes into and hopefully goes into a lot of detail about these inequalities and all the areas that we should be concerned about when we're thinking about the policy implications of the pandemic in terms of mental health. The Centre for Mental Health has also produced very good information about projected new and additional mental health need, and has talked about 8.5 million adults and 1.5 million children and young people needing this. So what do we do about that? Clearly, we cannot simply talk about treatment. Treatment is vital, but all of this information that we have today is sending us a clear signal and actually giving us something of an advantage in terms of trying to head off what is likely, if we don't do anything, to be a huge, ever-increasing clinical need for services. So addressing the risk factors at a much earlier stage, as indeed the government has done through the other actions that it took during the pandemic, but of course these have now been lifted. That's a very important approach. So prevention is critical. So that's prevention and early intervention, taking a universally proportionate approach so that there would be actions for everybody, but also increasing investment and support for those individuals and communities who are known to be at increased risk and where there are already indications that their mental health is deteriorating. So we need solutions in all these areas for everyone, for those at risk, and for society as a whole. And I'll come on to that a little bit towards the end in terms of what this might mean in relation to how we think about policy and mental health more broadly. This is something from Professor Sir Michael Marmot, who recently spoke at the launch of Build Back Fairer in Greater Manchester, where they have done some very important analysis of COVID-19 and are looking to take action range of areas to improve health equity and dignified lives. And I think that is a very important phrase, actually. Everybody should be accorded the dignity to be able to have good mental health and a good life. And we need to be paying attention to where the long-standing economic and social inequities are seen, which includes ethnic disadvantage. And we have heard about this already this morning. This is so very clear. And as we know, this existed before the pandemic. So we have got a perfect storm of starting in a not very good place and ending up in a worse one unless we take action. So we urgently need more investment in public health, and that includes public mental health. But the signs are not very good. We know that from 2015 to 16 and up to 2019-20, that public health grants to councils reduced by £700 million in real terms. The spending review, while it said that the public health grant would be maintained at its current level, did not offer any increased investment in the public health grant. And that was very disappointing. Neither was there any extension of the Prevention and Promotion Better Mental Health Fund for deprived communities, which the government introduced last year as part of its COVID-19 Mental Health and Wellbeing Recovery Action Plan. So in that plan, we did have important recognition of the increased action that is needed in a preventive way in the most deprived communities. However, there isn't long-term funding commitment to addressing that at the moment. And last week, the Local Government Association was warning that current public health services are at risk because there is funding uncertainty, because the settlement has not been announced yet for next year, and also Omicron pressures. So these pressures continue to affect public health in all sorts of ways. They highlighted health visiting, suicide prevention, and other services being under threat because of this. So we cannot assume even that the place we started off is the place that is a sort of guaranteed level of provision. Somewhat astonishingly, perhaps, the government decided during the pandemic to replace Public Health England with two new agencies. The UK Health Security Agency, which its inception was announced with as having a relentless focus on keeping the nation safe, although interestingly, that did not include mental health. There seems to be a separation here between big focus on infection and disease control, which is clearly not surprising, which seems to be attracting huge amounts of money, which of course is important. But our mental health security and safety is also very important, and this needs to be recognised. We also now have a new Office of Health Improvement and Disparities, which is within the Department of Health and Social Care. And again, this sort of came into being on the 1st of October, and we've yet to see how much funding it will be given and how much priority it will give to public mental health, which is important not only for, obviously, in terms of mental health in and of itself, but mental health is a component of all physical health as well. And this connection also needs to be respected and considered. So both these bodies need adequate resourcing and a focus on public mental health. And we hope they're talking to each other. New integrated care systems. In England, integrated care systems are the way that care provision is going. The Mental Health Foundation and others are working to ensure that the Health and Care Bill, which is currently in Parliament, will mandate public health and voluntary community and social enterprise representations on integrated care partnerships. We hope it will require the system to identify and address health inequalities, and also specify that there must be parity between mental and physical health in all the functions of NHS England, integrated care boards, and integrated care partnerships. This is an argument that's still going on. So there's no guarantee at the moment that these things will be happening in the way that they should. So I would encourage anyone who has any capacity to influence how this is evolving to do so, to ensure that these things are part of what we see when this bill becomes an act. There will be a new mental health strategy in England, and we very strongly urge that this has a strong focus on reducing risk and increasing protective factors for mental health, and that is a whole government strategy taking a mental health in all policies approach. We know that the vast majority of the things that affect mental health are not actually the province of the Department of Health and Social Care and the NHS. They happen out with those environments, but of course then when the need is great and it gets to a severe level, then the response is there. But in terms of preventing it, other government departments need to be a part of that. There are some exceptionally good, as you would expect, short, medium and long-term action recommendations in the Marmot Building Back Fairer report. So I would encourage people to have a look at those if you're interested in seeing what can be done in relation to these things. And I've talked already about how the voluntary and community sector should be part of what happens. I will just leave that quote there for you to see, but we know that often They are representing the most marginalized communities and individuals, and yet their funding can be very insecure, and they are not given the voice that they need at a local level in order to address all of the issues that we know need attention. So I would like to suggest, and it seems maybe somewhat perverse to do this in the current circumstances that we're in politically, but that we maybe try to refocus again on the feeling that there was at the beginning of the pandemic that this was affecting us all, that maybe we could do things differently when we come out of it. And this would include having a political consensus on the need for government action of the type that we did see during the pandemic, that was addressing poverty, financial precarity, homelessness, all these very important factors that pose a risk to people's mental health. We should move beyond GDP as our sole measure of success. We know that in New Zealand, it was after the Christchurch earthquake and the massacre there that they saw that GDP was rising, but that that people's sense of how life was not increasing. So they decided to create a well-being budget in order to pay attention to the things that people most care about in their lives and in their society. We need to go back to really shining light on those we valued during the pandemic, during the lockdowns, or health and social care workers and other workers who are so often taken for granted. And we need to act to reduce the loneliness and unwanted social isolation in our communities. We would like to suggest also that we think about kindness more and how that can become a part of policy thinking and delivery and approach. In 2020, the Mental Health Foundation, which hosts Mental Health Awareness Week, did a survey for the week in which we focused on kindness. And we found that 72% of the UK adults aged 18 or over said that it's important we learn from this crisis in order to be more kind as a society. And they also felt that politicians should value kindness more. I think there's a real danger that we forget all of this and we slide back into our old positions and where we were before. So there are very real challenges. We need to maintain a long-term focus on mental health. And we know there will be a big focus on acute elective healthcare. Match up with that. Should say, of course, that will be beneficial for mental health because of the impact of physical poor health on mental health. There's a strong relationship there, and depression can increase if you're not able to have treatment and support. We have a 4 to 5 year electoral cycle, which does make it harder to commit to and sustain long-term preventive action, but this is what is needed. And we need to have that bold vision to look beyond that time period and invest properly in prevention. And then can we increase public and political understanding of these socioeconomic determinants of mental health, maybe reframe the discourse on mental health and manage to reorientate our national, regional and local governments and, crucially, voters towards prevention. So I've just got some key references here and contact for further information. And thank you